All right, let's talk about turning that absolute mountain of clinical facts you have to know into something you can actually use. A lean, powerful toolkit. This is your high-speed review for when things get real.
I mean, that's the big question, isn't it? You're facing an avalanche of information every single day. Look, the secret isn't about memorizing every last detail. It's about having a system to find and apply the right information right when it counts.
And that's exactly what we're going to do. We're going to build that mental framework together, piece by piece, so your knowledge is organized and ready to go at a moment's notice. Let's dive in. First things first, it all starts with observation. Before you can even think about analyzing or acting, you have to be a master data collector. And that begins with a rock-solid, systematic physical assessment. The master blueprint here is the classic head-to-toe assessment. It's your safety net, a methodical routine that makes sure you don't miss a thing. You start big with a general survey, and then you systematically work your way down. Now, to really see this in action, let's zoom in on one of the most vital systems, respiratory. Your assessment kicks off the second you lay eyes on the patient. This isn't passive looking. Inspection is an active process. What are you seeing? What is their body screaming at you before you've even laid a hand on them? You're scanning for these visual red flags. Look at their work of breathing. Are they using those extra muscles, sucking in at the ribs? Are they leaning forward in that classic tripod position, just struggling for air? Check their skin. Are they looking blue? That's cyanosis. And their breathing rate. Is it crazy fast or dangerously slow? These are all urgent clues telling you something is very wrong. Okay, so after you've looked, you listen. Auscultation. This is where you become a detective, translating the sounds you hear into a potential diagnosis. Every single sound tells a story about what's going on deep inside the lungs. And each sound is a major clue. You hear crackles? Your brain should immediately go to fluid, like in heart failure or pneumonia. Hear wheezes? That's narrowed airways, the hallmark of asthma. But listen, if you hear stridor, that high-pitched, desperate sound, that is an absolute drop-everything emergency. It means the upper airway is closing. And don't forget, sometimes the most terrifying sound is no sound at all. Silence could mean a collapsed lung.
So, you've gathered all this raw data from your observations. Great. Now what? The next tool in our kit is analysis. This is all about interpreting that data, recognizing the critical numbers and the key patterns that are going to guide your next move.
Let's start with a big one in neurology, a Glasgow Coma Scale score of 8 or less. Now, this is not just some random number. It is a critical line in the sand. It tells you the patient is in a coma, and more importantly, they probably can't protect their own airway. You know the saying, GCS less than 8, intubate. It's a classic for a very good reason.
Hopping from neuro to immunology, here's another game-changing number, a CD4 count below 200. Just think of that CD4 cell as the general of the immune system's army. When that count drops below 200 in someone with HIV, the general is gone. That's what defines the shift to AIDS, and it basically throws the doors wide open for all sorts of nasty, opportunistic infection.
Now, in stroke care, the NIH Stroke Scale is your yardstick for figuring out just how bad it is. A score from 1 to 4, okay, we're likely looking at a minor stroke. But once that number starts climbing past 15, and especially over 20, we're in severe stroke territory with a much higher chance of serious disability. This scale literally guides treatment in real time. You know, analysis isn't just about numbers. It's about spotting patterns that help you tell two very similar-looking conditions apart, like with inflammatory bowel disease. So what's the difference? Well, think of Crohn's as a chaotic traveler. It can pop up anywhere from the mouth to the anus in these patchy skip lesions, and it digs deep through the whole bowel wall. Ulcerative colitis, on the other hand, is a homebody. It stays in the colon in one continuous pattern, and it's much more superficial. Knowing that pattern is everything for getting the diagnosis right. Okay, so you've observed, you've analyzed. Now it's time to do something. It's time to act. This part of our toolkit is all about interventions, and we're going to focus on some of the absolute biggest players in pharmacology. So much of pharmacology really just boils down to messing with the body's autopilot, the autonomic nervous system. It's like your body has two pedals, the sympathetic system, which is your fight-or-flight gas pedal, and the parasympathetic, your rest and digest brake pedal. Honestly, if you can understand this simple duality, you can understand how hundreds of different drugs work. Acting with drugs also means knowing the risks. So let's do a quick-fire round of toxicity flashcards for common antibiotics. First up, fluoroquinolones. The one bizarre risk you have to burn into your brain is tendon rupture. Yes, really. Next up, vancomycin. Everybody knows this one. If you push it too fast, you risk red man syndrome, that classic all-over flushing and rash. So what's the takeaway? Slow the infusion down. And finally, the big guns, aminoglycosides. These are incredibly powerful drugs, but they carry huge risks. We're talking ototoxicity, damaging hearing and balance, and nephrotoxicity, destroying the kidneys. With these, monitoring is absolutely everything. And sometimes, the most powerful action you can take is a reversal. In the world we live in today, with the opioid crisis, there is one word, one drug, that every single person in healthcare has to know: naloxone. It is the life-saving, essential antidote for an opioid overdose. Period. Okay, the final tool in our kit. This one is your safety net. It's all about verification. After you observe, analyze, and act, you have to circle back and double-check. You have to verify that what you're doing is right, safe, and effective. These are the non-negotiables.
A perfect example of a core safety protocol is accurately staging pressure injuries. Getting this right is so important. It all starts at stage 1, which is just some red skin that doesn't turn white when you press it. From there, it gets progressively worse until you hit stage 4, where you have full thickness loss and you can actually see exposed bone or muscle. Staging it right from the start ensures the patient gets the right care.
And here it is, maybe the ultimate verification tool of all time, the rights of medication administration. Seriously, think of this as a pilot's pre-flight checklist. It's a systematic process designed to prevent catastrophic errors. It might seem like a lot to remember, but every single item on this list exists because of a mistake someone made in the past. It's the cornerstone of patient safety. Every right, every single time. So there you have it, the system. Observe, analyze, act, and then verify. The toolkit is built, the tools are in your hands, all organized and ready for action. So the only real question left is, how are you going to use it to make a difference for your patients on your very next shift?